responding to a trauma, okay? Somebody that's coming in from the outside hospital center, they're called code yellows, I don't know what they're called at PG Hospital, but respiratory therapy is on the team to respond to these traumas. So somebody could be coming in from the outside where the EMTs or paramedics couldn't get them intubated, so they're gonna use another emergency airway, so that's why you have to be familiar with the airways. But in the clinical setting right now, you're gonna be seeing oropharyngeal and nasopharyngeal airways frequently, okay? When we say pharyngeal, oral, or nasal, we're not talking about going through the larynx. These sit in the pharynx, either the nasopharynx or the oropharynx. That's it. They do not go through the larynx, okay? The Combitube might, but these are blind intubations, so the likelihood is they're gonna go in the esophagus, and we'll talk about those. The LMA is the laryngeal mask airway. It's used almost all the time in the OR for short cases, okay? Instead of putting a tube through somebody's larynx, they use a laryngeal mask airway and they ventilate through that. So again, what you guys are gonna see are the oropharyngeal and nasopharyngeal. Which do you think is the nasopharyngeal? Yup. Okay, so this goes in the nair and sits just below the uvula, okay? And this is the oropharyngeal, and the purpose of this is, I remember I showed you this when we were talking about resuscitating with the bag at a code. I said, I always carry one of these in my pocket. Do you remember why I said that? What do they do? What do you think these do if these go in just in the mouth to the back of the tongue? Holds the tongue in place and down so that, because when you're unconscious, what happens to your tongue? It drops back, it occludes the airway, okay? All right, so which could be used in a conscious patient? Conscious.
Conscious, maybe oral.
The nasal. Why would you not tolerate an oral if you were awake? Has the doctor ever put a tongue depressor in your mouth to look at the back of your throat? What do you guys do? Right, and then you can throw up and aspirate. Never to be used in a conscious patient. Can be used in a conscious patient. Okay, got it? That's pretty easy, okay? Now, everyone hold this up and this up and look around the room. A lot of different sizes here. I don't think I would want Jovi's in my nose. Jovi, hold them up. Okay, all right. Everybody look at your your oropharyngeal airway and your nasal airway there. No, hold them up like this so everybody else can see. See all the different sizes?
Oh.
See, now do you see? All right, so you have to know how to size them for a patient. Because if you put in one that's too big, like if that actually got in my nose, God, it would hurt. But that would probably, the tip of that could hit the larynx and actually cause laryngospasm, okay? So you don't want that. So what we're gonna do in this lecture is, what's the indication form? We already said, move away soft airway obstruction, the tongue for this. What else? If you had an endotracheal tube in, and this was in your mouth alongside the endotracheal tube, feel the end of this as compared to the back. Feel this right here, right after the flange. Try to press that, and then try to bend that, but then try to bend this. Does this part bend?
No.
It's hard. So that goes, where do you think when you're placing it? Behind your teeth or at your teeth?
Had your teeth.
Yeah, so if you had an endotracheal tube in and you were biting on the tube, we say grab a bite block. That's what the oropharyngeal airway can be done. You can put that bite block in so that when they bite, because they could bite the pilot balloon right off those tubes. I've had that happen. Okay, and that's it. You can't put air in the cuff. It's leaking like crazy. Or they could put a slight hole in the tube. So this way it prevents them when they bite, they're gonna bite down on this. But we got better medications in the hospital now for sedation. If somebody is that agitated, you need to sedate them better. Because you have one more thing in your mouth, it's not comfortable. But we have used them to prevent a patient from biting down on the endotracheal tube. Okay, but ideally you should sedate them or figure out why they're agitated. Maybe they can't breathe, okay? So before you sedate or before you do anything, figure out what the problem is. If it's pure agitation, try to sedate, okay? If for some reason they can't sedate because their blood pressure is low, you might have to use this pipe lock, but it's another thing in your mouth that people don't like, all right? Why do you think we might put this in somebody's nose? You learned about something that could cause a lot of trauma in the nose. What do you do in the patient's nose that could cause a lot of trauma? Suction, great. Nasotracheal suctioning, when you go in to somebody who can't cough, who has secretions, they're awake, they're alert, but they're very weak, they've got a lot of secretions, they can't cough, okay? So we have to anti-suction them. Well, all of a sudden you're anti-suctioning them every 2 hours. You start getting blood, because that's a lot of trauma. You put this airway in the nose, and then you can suction in through that. It's also an alternative to somebody who's seizing. When somebody seizes, what do they do with their mouth? Is it wide open? Have you ever seen a seizure? They clamp down, they're rigid. You can't get anything in their mouth. They can bite their tongue badly, okay? But you can't get anything in there. You pass this down, and it allows, the tip should sit where it would direct air to the trachea, okay? So, all right. Okay, so let's just look at this, all right? So what you want to do is if somebody's ever going to put one of those in you, you certainly want to make sure that they measure it so it's not too big. All right, so, okay, pharyngeal airways don't go in the larynx, they only go in the pharynx. So we got the nasopharyngeal airway or the oropharyngeal airway. Endotracheal tubes, you know, this seems like a no-brainer, but when you're taking a board exam, the question will say, which of these tubes is considered a laryngeal airway? And students get so thrown off and they start answering nasopharynx, oropharynx. No, laryngeal, it goes through the larynx. ET tube. Does a trach go through the larynx? A tracheostomy tube. Through the larynx. No, trachs don't. They go in below the second and third tracheal ring. They go below the larynx. So it's not considered laryngeal tube. Yeah, it's a trick question. You think, well, what do you mean, you know? But it doesn't go through the vocal cords, okay? All right. Okay, so intubation, Joni told you what that is. That is the placing a tube either through the mouth, oral ET tube, or through the nose, a nasal ET tube, okay? All right, so our pharyngeal airways, here we go. The major point with these is to prevent airway obstruction. So even the nasopharyngeal goes below the base of the tongue, just below the uvula. So you have, if you're breathing through your nose, air movement is directed into the trachea beyond where the tongue would be, okay? Okay, so oral, this is something, pay attention, it's contraindicated in patients that are awake. Why is that? You guys just told me what happens if I stick a tongue depressor in your mouth, you gag. Well, you're gonna gag with this. So you never wanna use an oral one in an alert patient, okay? Okay, so how are they put in? All right, we'll talk about that in a minute. All right, the tube that you guys have, pick this up. Does it look like this one?
No.
No. This one is called a Berman. Think about B for bi. In other words, it's got channels on both sides, 2 channels, bi, all right? Though that would be, and they are harder, pass this around. That's a Berman. And the reason why I put this down is because, here, you guys pass this way. These are hard, they're not flexible, they've got channels. Right on those channels, like if somebody gets a lot of oral secretions in, you could slip a suction catheter to get that stuff out of their mouth, okay? They are hard, they're not flexible like this. So, 2 types of oropharyngeal airways. The Berman, which has dual channels, think B by 2, okay? Or this is called a Goodall. Now the boards used to ask the difference, okay? You never know whether it might be slipped in there, or whether they're just gonna say oropharyngeal. But those are the 2 types of oropharyngeal airways. One is more rigid, one is more flexible, okay? This is the good doll, which you guys are holding. It only has one channel. You can put a suction catheter into that channel to clean it out, okay? And it's only rigid at the part that goes between the teeth. That's it, okay? So, what's the main indication for oropharyngeal airway? Unconscious patients who have, why are we putting it in? Why would you think about putting one of these in?
Obstructs airways.
To what?
Obstructs airways.
Obstructed airway?
Yeah.
What's obstructing it? The tongue. So it's to remove like any soft tissue obstruction. And basically that's the tongue when you're laying down that's dropping back. Why do you think people snore? Okay, what happens? If they're laying on their back, their tongue drops back and obstructs the airway, so they're like that, okay? Got it? Okay, all right. So, indications, unconscious, or, like I said, to avoid soft tissue obstruction when you're trying to bag somebody, okay? Or to prevent them from biting on the ET tube. So that makes sense, right? All right, and contraindications, conscious patients, or anybody, of course, that has like busted up, teeth. There's one, trauma, I could see somebody's chest split open, I could belly, whatever, but trauma to the face always freaks me out. I never liked going to the dentist, so that may be it. Trauma to the mouth and teeth just makes me crazy. But of course, you would not want to put one of these in, okay? Okay, so how do you size it? All right, you go from the lip, the side of the lip, right here. Okay, you take the airway, hold it up to the side of the mouth, and this must go to the angle of the jaw, okay? And that would be here. This is the angle of the jaw, okay? So it's from the side, from the teeth to the angle of the jaw, okay? And that's adequate. If it's too long, it could cause a spasm, okay? So you want to go from the angle of the jaw with the teeth parallel, with the flange parallel to the side of the mouth, the teeth, okay? Because you're gonna put this in, and when you insert it, we're gonna talk about inserting. So this is just size it. Now, what would happen if I inserted it this way? What could happen with the tongue? I could push it back more. So the way these are inserted is upside down, in, when you're almost all the way in, you turn it around, and then push it flush against the teeth. So bring your airway up and put it in this guy. So you never want to go this way. You guys want to put your gowns on? Throw your gowns on since you're going to be closer. Okay, so you never want to put it in right side up. So you're going to push the tongue down. And some of you have bigger airways. So you want to make sure when you're looking at your lab, hint, hint, that by looking at a picture, you can identify the airway, okay, for the future. All right, you're done first, Henry, up you go. All right, so first I want you to see how it's sized, okay? Turn it the other way, okay, just set the up to the angle of the jaw. So that looks good. All right, now you're gonna put it in almost all the way, and now you're gonna flip and push. Yep, okay, got it?
Yep.
All right. Shown, measure from the teeth to the angle of the jaw. Okay, you're looking good. All right, now put it in, almost all of the way. And now flip and push all the way around, flip and push back. That's it. You never secure these with tape, ever, okay? All right, they just go on like that. We've seen therapists tape them, you don't tape these, okay? All right, Demi-Lola. Okay, the measurement, teeth to the angle of the jaw. You're good, you all have the same airway sizes. Okay, now go ahead and put it in. And almost all the way, and then turn it and push. Okay, you wanna, before you get it all the way in, okay, when you're about here, you're gonna turn and then push, okay? Because you wanna pass, you wanna be rolling across the top of the tongue, so that when you turn it, you're on top of the tongue, okay? Good? Now you gotta remember, your patient's gonna be unconscious, so do you have to worry about, he's gonna go ow, ow, ow? No, okay? All right, go ahead and measure it. How do you measure it? No. Turn it like this. See how they're doing it? Side of the, from the teeth, okay, to the angle of the jaw. Good, that's a good size. Now turn it and push flush with the lips. Good, okay? Now if you got an endotracheal tube in there, you've got to go to the opposite side, or you may have to, move the tube. There you go. Okay, Sylvie? Good, yep, teeth, side of the mouth, yep, angle of the jaw, that's good, all right, up, yep, turn, push, good, okay, all right, Patea? See how you're measuring? Good, angle of the jaw, good, you're good, okay, now put it in, keep going, now turn, flip, push, flush, good, very good, okay, great job. Okay, so, you can put these in a conscious patient, true or false?
False.
False. You measure it by putting it to the angle of the jaw down to the tragus plus 1 inch. False. That's gonna be the nasopharyangeal, okay? Okay, these are indicated if the patient is biting on an ET tube.
Yeah.
True, okay? All right, you can, the Goodall has 1 channel. True. B for bi, 2 channels. There you go. Okay? All right. Okay, so you can use them on your bag mask ventilating to keep the tongue out of the way. You can use them on an unconscious but breathing patient whose tongue is dropping back, or you can use them on an awake patient who's very agitated and biting on the ET tube if for some reason they can't sedate. Okay? All right. Okay. Okay, and you tape these. True or false?
False.
False. It is left unsecured. Okay?
Say that again,
You do not tape this. You do not put a piece
Oh,
of tape
tape.
in. Because
Okay.
what happens is patients wanna use their tongue and push them right out of their mouth. And they like to do that with ET tubes, and if ET tubes aren't secure, they can work an ET tube all the way up, okay? But if they're doing that, they need better sedation, okay? Okay. All right, so what are the risks? The major hazard is, where is my major hazard? Vomiting. Why? You've got something sticking in the back of your mouth, so you can vomit, you can aspirate, okay? A dental trauma, that makes sense. You jam this in and you could break the teeth, especially if someone's biting down trying to get one of these in. So these all make sense to me. If it's too long, the tip can catch the larynx and cause laryngospasm. What happens? The vocal cords snap shut. They won't open. Okay? All right, airway obstruction. If it's too small, see, I don't think you have to memorize these. I think these make sense. If it's too small, you're gonna push the tongue back and obstruct the airway, okay? All right, gagging and coughing makes sense, all right? Pressure necrosis. If somebody taped one of these things and pushed real hard and pushed against the lip. That's pressing there for a long time, you get a pressure ulcer, you can get a breakdown of the lip, okay? All right. Okay, so nasopharyngeal airways. So one of the main indications for these are for frequent NT suctioning, okay? Frequent NT suctioning, again, in a seizing patient whose mouth is clamped shut, you can't get this in, you wanna make sure the tongue's not dropping back, you put this in a long enough one that's gonna divert air into the trachea when he's breathing. All right, so, can you imagine, what's the first thing, you're gonna put this in someone's airway and you're gonna size it. What's the first thing you wanna do? Hold yours up, Joey, near your mind. Is the diameter different?
Yeah.
Yeah. So what's the first thing you're gonna do when you're trying to size this for diameter? You don't need to look, it's going in your nose. You want it to fit what? Snug, right? Snug? So the outside diameter needs to be slightly smaller than the inside diameter of the nostril. If it's too big and you're jamming it in there, you're gonna cause a lot of nasal trauma. So the outside diameter should not be larger than the inside diameter of the nair. Now, how do you know how long to go down? What's the tragus? Does anybody know? People pierce the tragus a lot.
Well,
The tragus, it's called. People pierce their earlobes, but they also pierce their tragus. You know what the tragus is?
it's between the mouth.
This is that piece of semi-cartilage right here. They pierce that,
Yeah.
right? Okay, so you can see on a board exam, they may say one of two things. Okay, you're gonna size this, you're gonna go on the side, okay, of the nose, the nair. And you're gonna go to the tragus, and you're gonna add an inch. If I add an inch, where am I? If I add an inch to here from the tragus, what do you call this? My lobe, the ear lobe, okay? We're gonna teach you, you measure from the nostril to the tragus plus 1 inch. Some board exams could say from the end of the nose to the earlobe. Well, that is the tragus plus 1 inch, okay? Okay, so I want you all to come over here, and I want you to come and put in, you all have your gowns on, so come on up, okay? Now, there's a bevel on this. Okay, there's a bevel. Everybody see the bevel? Okay, the bevel, you wanna face it slightly towards the septum. So, I don't wanna go in like this. I don't wanna go in like this. I wanna slightly face it towards the septum, okay? And what I should really do, and angle it down, and then you're gonna push it so that the flange is directly next to the nose, okay? And it stays in, like that, okay? When you're putting it in somebody, I think I'll have you all work on this one. Okay, when you're putting it in somebody, you always wanna be gentle. Because once it's in, they're okay. It's going in, just like nasotracheal suctioning. Okay, so you just go very gentle, give them a second, start to angle down. You're gonna have to go through a little bit of a obstruction, like I'm hitting right here. There we go. And force it, okay? Can you do it? Okay, so, in. Point the bevel towards the septum, and then you're gonna go straight down. There we go. If you're hitting or jamming, don't do what I did initially. If you're hitting that resistance, find the sweet spot, well, it goes down. Okay? There you go. Now, let's measure that just for the hell of it. Nose, tragus, that's about a 1/2 inch, so that's a little too short. All right, but go ahead for putting it in. Because this you will have to do with somebody who's alert. Now, did you feel resistance? Oh, there you go, you got it. You see, once you pass that little bit of resistance, good job, you can take it out. Could you do that to a real person? Okay, then Lola? Yep, go ahead and try.
So you should have said before, when you
I don't usually take it fully out, I go to, because if it freaks anybody out the first time you're going in their nose, just like NT suctioning, I never take it totally out. Which way is your bevel? Yep, towards the septum, when you're first going in. All right, now when you hit that resistance, you hit resistance. Okay, now you don't jam it, just work it until it goes. There you go. You see, you need to get by that one spot. And that's when they're going, ow, ow, ow. And you're freaking out. Okay. So you get the feel for it. Again, it's just like NT suction. You do feel a little resistance initially, and then you know once you've gotten it past that area. Bevel towards the septum. Yep. Toward the bevel is this is the angle right there, the bevel. That's towards the septum, okay? No. This. It's just facing. It's facing. Turn it so it's facing. No. There you go. Got it? Okay. Jovi? Yep. You're gonna feel that resistance. Take it easy. There you go. Think of your own nose. No, don't do that. Don't be like, you're gonna get it whether you want it or not. Now, see how that's a little short? This is the tragus right here. Okay, you need another inch. Okay, so it's a little short. Wow, you nailed that right away. Okay, I might let you put one in my nose. Jovi, I'm gonna hold you back for a little while. Okay, all right.
Are you thinking code 10?
Okay,
Oh
don't.
my God, I did like
You
that.
can go from this,
Painful.
touch it up here.
I
Because
was
you're gonna have
wondering
gloves
if
on.
this is painful more than that.
Okay, so find that sweet spot where it goes right down. Okay, bevel towards the nose. Okay, come here. I'm gonna guide it for you. You're gonna feel. See the difference?
Yeah.
Try it again. How come that worked for you? It didn't work the first time for me. Oh, you need Joni? Okay. Go ahead and, yeah, bevel towards the nose. But when you hit that sweet spot, it goes right in.
So this goes on the left side. No,
A lot of it is making sure that bevel is pointed towards the septum, guys.
It's not different.
Yeah.
So this
Right.
way.
Louise, she's coming.
And you go this way. So this one, you go this way. The middle, face the middle.
So it's almost all which way you're pointing the
On
bevel,
the left side.
okay?
On the left side.
Bevel is pointing in. Okay? All right. Just work it a little bit when you feel that restriction. You know, the natural tendency is to want to try and push it, but it should slide in. So wasn't that good to get a feel for that? Okay? All right. And just remember, on a real person, you know, they're like wincing, they're trying to stay still, so always gentle. Wait, and then redirect a little bit. Okay? Got it? All right, let me collect all those nasal airways. And the oral airways. Okay. Thanks. You? Just gonna put these away real quick. Here. So you see our 2 points for nasotracheal suctioning and for seizures if you can't get back there. Now here's the one problem. There's what we call the cranial vault. You never put these into somebody that has a basilar skull fracture or some kind of, or an ethmoid fracture or anything like that. Because you could go into the cranial vault with these things, which is brain, okay, into that, in through the skull, all right? So there is a picture right there. You see that little round airway? That's one that has gone through the cranial vault. So if your patient that has a basilar skull fracture, number one, you don't want to NT suction them. You don't want to put in a nasopharyngeal airway because of that risk. Though rare, it can happen, okay? And if I had somebody with a basilar skull fracture and they were telling me, you know, to NT suction the patient, make it aware, you sure about that? Because basilar skull fracture, it's not an indication. So always be aware of that, okay? And this is the tragus of your ear. What I was saying is pierced. So you want the end to go to the tragus plus 1 inch, which takes you to the earlobe. And then on the board exam, sometimes you may see from the nair to the earlobe. But you guys answer with the tragus plus 1 inch, okay? Okay, all right. Too short, you won't get airway patency because the tip will not guide air movement down into the trachea. And then of course, too long, again, you could tip hit the epiglottis and you could cause laryngospasm, okay? So, I sprayed these, okay, with the lubricant for there, but KY jelly, which you get in the hospital in a little packet, you always lubricate this with the KY, or lubricating jelly, always on the outside. So you open a little packet of the KY jelly, squirt it, and rub the nasopharyngeal airway all around, put that jelly all around, then you insert it, okay? You never want to put that in without lubricant. Okay, so, again, trauma, here's the key here. To avoid tissue necrosis, change sites every 24 hours, okay? These things, if you don't have to use them, great. If you have to use them, you don't have a choice. But when they're sitting in there, people can develop sinus infections, okay? So if we don't have to use it, great. If we're only suctioning like, you know, once a shift or something like that, you wouldn't use it. But if you're suctioning somebody every 2 hours, you would need that, okay? Okay, so the top 2 are emergency airways that are used by the paramedics and the EMTs out on the field. Paramedics can intubate, but if they have a difficult intubation, they are left with having to put in a tube blindly. The key with the top 2, the King and the Combitube, I'll tell you now, the Combitube is no longer used in the field. That's not to say somewhere you might not find it. The King tube has replaced it. But they are done blindly in order to access an airway to somebody who may not, for some reason you can't get them tubed. You can't get access to the trachea, okay? All right, come over here, well, we'll talk about the Combitube first, okay? Can you guys share? Okay. All right, now, never will you see this in the hospital unless somebody's coming in from the outside and they couldn't establish an airway. And what tube did I say you would see instead of this? The King. It's much easier to use. All right, so we'll go over and I'll put one of those in this guy, okay? But first, you need to figure out what it is. All right, so pre-hospital for an emergency airway if you can't intubate somebody in the field. For some reason, they can't get the tube in. Because in order to get an ET tube in, you have to use a laryngoscope and visualize the vocal cords, right? Okay, if you can't do it or you're not trained for intubation, these emergency kits, they carry King tubes now. But the precursor to the King was the Combitube, and the Combitube is still tested on the boards. All right, you see two balloons. Look at your tubes. You guys need to get closer. Feel the love, okay? There you go. All right, now, look at the big balloon. What does it say on that balloon? Does it say anything? On some people's, it should say 80 milliliters. 80 milliliters of air gets put into that. Where is that big tube sitting? This is the epiglottis right there. Where's that big tube? What do we call that right there? What kind of pharynx is it? Is it the nasopharynx? Oropharynx. That big fat thing is in the oropharynx. Look at your tubes. Look at the top of the tube. There's two tubes. One says one says two, right? Okay. Now look at the bottom of the tube, head on.
Yeah.
Bottom, head on, like this. What do you see? What do you see? That's it, head on. What do you see? One is what, Jovi? One is closed, one is open. Which tube goes down to the closed area, the blue one or the white one? The blue one. Okay, so,
Hey, excuse me, Nina Howard is not coming here.
no, we're going
So he
to,
was saying that these need to go back, and that needs to go back, because that's incomplete, but I said, Howard's not coming here.
right,
So I asked him if he could take them back.
yeah, and then they'll send us something?
They're gonna send us
Yeah,
some
Howard's
replacements.
having us sit in front of, we're gonna Zoom, and we're gonna have two
That's how we're doing
simulators,
it with
and he's
Howard.
gonna Zoom. And then we're gonna work on it like that.
So
we'll-
we're missing this for that one, and they're gonna send it in the mail. And then the two ones that fit for our compressors, which will be set in it, they'll send it to us. So he's taking that back with him.
The compressors, when they're not doing this, so the compressors will that stuff come with the compressors? It won't?
That's a separate.
Okay.
Yeah, they'll
I mean, is that,
separate.
can you handle that for us, please?
The compressor?
No,
No.
bring that back.
Oh, yeah,
Oh,
okay.
this is gonna be, the replacements will be shipped.
They will, everything will be shipped
Everything will
here,
be
so,
shipped.
okay,
I'll have this one shipped.
okay,
Anything else
perfect.
in here?
Perfect. Okay, so when you look at that, guys, the bottom of it, one side's blocked. The blocked side is to the blue tube.
Yeah, yeah, I was like, I mean, like.
The clear side is
So-
open,
He's working all the time.
right? So I want you to think about this. If I'm going in blindly with this whole tube, where is it likely to go? Trachea or esophagus? Jovi says esophagus. Huh? Yorda says esophagus.
It's just running your battery now, right?
Why are you guys saying esophagus?
So maybe we didn't want to ship it in.
And what can't you see? What do you absolutely have to be able to see to get a tube through the vocal cords? Vocal cords. You gotta be able to see the glottis. You need, and what do you use to be able to see it? Laryngoscope. You gotta get in there with a laryngoscope, lift up, look at the cords, and slide the tracheal tube in. You're going in blindly. The likelihood is you're gonna go into the esophagus. So, the blue tube is the one, if you're supposed to put your bag on when you're in and squeeze it. All right, do you want air to go into the stomach?
So, you and I.
You want air to go into the lungs. So I want you to look here. This tube, where is that placed right now? In the trachea or esophagus? What's anterior, trachea or esophagus? No, right, when you feel right here, are you feeling your esophagus or trachea? It's your trachea. The esophagus is behind the trachea. Your esophagus is behind your trachea, guys, okay? Where is this tube placed? Where is it?
Trachea.
Where's your trachea? Trachea's in the front.
Oh,
Esophagus is in the back.
oh, okay.
Everybody see that? Where's this tube?
Esophagus.
Okay, so if you, so number 2
You know, being respiratory therapy.
is where that tube is, if you're bagging and the chest is rising, you're in the esophagus. Because if you're squeezing that bag, oh, I promised that on there. Darn it, darn it. Okay. So if I'm in the esophagus and this is blown up in my larynx and this is blown up further down and I squeeze air in, how is air getting into the lungs? Because it can't come out the bottom. Through the holes. So through these holes, because this is totally sealed down here. And if you bag the blue one, does the blue one have a port at the end? An open port? No. So if you bag the blue one, the air is gonna go down. Can it come out the bottom? No. And if it comes out these holes, can it get beyond this balloon? No. Can it get above into the mouth? So where's it gonna go?
So it'll be hooked into the wall like that.
Down to the lungs. Got it? Does that make sense? All right, so I'm gonna put this tube in over here. Come here.
You would think that would be more downstream.
Now, did you guys get to look through the
It's
microscope?
supposed to be down here.
Did you get a chance to look or no? When I say you have to see the cords in order to get in, come here. All right, so if I was gonna put an ET tube
Oh,
in,
yeah, we're not doing that. Yeah.
oh, this one doesn't have the, shit.
Uh-huh.
Have you guys ever looked through here? Okay, somebody look
Okay.
through there right now. Look through there.
Okay,
You
so that'll go up to
see
that end and that'll go. up there.
Trachea?
Okay, all right. Yeah, that's easy.
That's the
So
trachea.
the compressor comes in and the compressor sits down there.
See the hole?
And then we'll have a
Oh,
short piece.
that's the
going through
trachea.
Compressor.
Okay? You see it?
Yeah.
Okay, that's where I
Oh, you
slip
are
the ET
installing
tube
the
in.
compressor.
You see the
Oh,
hole,
it's
the
really back
trachea?
to that. Okay.
Do you? Okay, everybody look. You see the trachea? Okay. See it? Gotta get down.
I think it's,
See the trachea?
Howard.
Okay, now,
I don't think.
in order to, so I'm looking, and then I slide the tube right through the hole. But if I'm going in blindly,
Yeah, so,
Where's
yes,
that
they're not
stuff?
coming in here, so we're
Okay,
just, we're
so
not
I'm
even
out in the
going
field.
We're just gonna be doing it on virtual. But at least I think it's like.
the person needs to be intubated, and I don't know how to intubate, okay? So, I take this tube,
Okay, so what's up, what's this here?
I slide it in,
Okay.
all the way in, up to here, okay? Now, it always goes in between, right up to the black line, okay?
Uh-huh.
Did I see the trachea?
Oh.
The likelihood is it's in the stomach, but I have to make sure,
All right, sounds good.
okay? So, I inflate these balloons. The blue one is the pharyngeal,
Right,
okay?
right.
So I'm gonna push 80 cc's into there.
We'll fix it.
All right, now, I want y'all
We're
to
not coming.
look in his mouth and see if you
Yeah.
see the blue balloon in
Yeah, so
the
they must be
yellow
going
balloon
to
in the
hospitals and
pharynx.
educating at hospitals.
Here, go ahead and look.
And we're here, so that is weird.
Anybody have a flashlight?
They're taking us out
Flashlight on your phone?
because I'd rather go to college than a hospital.
Okay, so shine it in there and look for the pharyngeal balloon.
It's weird. Okay.
See the yellow? Okay, okay. Can can you hold your flag, can you hold that for everybody? No, she'll
Oh,
hold
it's
the
not
flag.
up to the front, yeah,
Okay.
it wasn't. Oh, of course we'd rather have him.
No, don't touch Sean's phone.
Yeah, I'd rather have him come here.
You
than
see the
have him
yellow
do it
balloon?
virtually. That's-
In the pharynx,
You wanna
okay?
touch the screen and all that, you know? Flashlight, so, yeah, okay, sounds
You
good.
see the yellow?
I'll figure that out.
The yellow balloon. That's yellow, that's the blown up balloon, that's that balloon blown up.
But I don't know that they're willing.
That's this, blown up, it's in the pharynx.
So,
See it? So that's sitting in the pharynx. Henry, did you see it too? You see it, Jovi?
but even the educators, right?
It's blown up in the pharynx, okay? Okay, now, we have to load up the smaller balloon, and then we have to bag and
Alright,
see
yeah,
where
that'd
the
be
tube
great.
is. It tells you to bag where first, the blue or the white. Where's the number one?
So, yeah.
The blue, okay?
Yeah,
Now,
we got a lot going on here.
if the lungs rise,
Thank you so
it
much.
means I'm in the esophagus and air is being directed through the holes down into the lungs. Okay?
Huh? Details, we need to know that stuff.
Right? Now, if I didn't if I didn't get chest rise, that means somehow I ended up in the trachea.
Huh?
Okay, but what happens
Yeah.
to the stomach
Yeah,
if I
I can
was
do
to
that.
bag this? Am I putting air in his stomach? What's gonna happen next? He's gonna throw up. All right, so when you put these in blindly, okay, go back and look at your tubes. When you
Hi,
put-
Keisha.
did I take somebody's tube? Here,
We
go.
got one more box,
I took
but
yours.
that won't
Go,
be till
did I take
next
yours
week.
too?
No.
Okay, go back and look
And
at
I'm
your
gonna have
tubes.
all of our homeowners back in that, right? And then all of the state and getting them all back. See that?
So, where's this tube gonna go? Likely? Where? The esophagus, right. And why the esophagus?
All right, thank you so much. Nice meeting
Say
you.
it again. Going in blindly, the trachea is more anterior, it just slides down the esophagus. It's like trying to NT suction someone, you can't see the trachea, and most of the time, you go in the esophagus, okay? So it's first of all, why are these used?
When you don't know how to do intubation.
You don't know how to intubate, or you can't get the patient intubated. You don't know how, or you can't get the patient intubated. And it's an emergency airway tube. So you go in blind, slip it right in. How far do you go in?
To the circle.
Up to the lines, the
To the
black
line.
lines, okay, at the teeth. You go in, and then there's a number 1 and a number 2. The number 1 is the blue tube, where that inflates which one?
The blue.
The big fat one, which sits in the pharynx with 80 milliliters, okay? Then you blow up the little one. Then you take your bag and you look for chest rise. That's what you're looking for. And you first bag on which one? The blue one. You follow the blue all the way down, and that's the blocked port, right? If you got chest rise, you're in the esophagus, air is going down, but it can't get out the bottom, so it's forced here through those holes, and it goes right up. It comes out of these holes, goes right up and then down into the trachea, and that's how we got chest rise. If the chest did not rise when you bagged number 1, where is the tube? Trachea. Where is the clear tube going? Is it open at the bottom? Yes, that's in the trachea, and this balloon is like an endotracheal tube balloon. It prevents air from coming around the tube, and it goes right into the lungs. Does the Combitube make sense? Does it make sense? Emergency airway, okay? So, replaced by the king tube, okay, so it's a double lumen tube. One side is open at the bottom, one side is closed. The open side would be as if you were in the trachea, the closed side's when you're in the esophagus, okay? So it has 2 puffs, one that closes off the oropharynx, because if it didn't have that and you If there was no big thing here and you squeezed, where would the air come out of those holes? Where would that go instead of direct into the trachea? It would come right out your mouth. That's why that tube is there, okay? And then there's a lower tube, all right? So, okay, so the multiple openings are where the air comes out, okay? Or it comes out the bottom. So here's an insertion. Let's look at this. Oh, I have this.
This demonstration will be the proper insertion of a Combitube. Of course, the first step you want to take in any medical procedure is make sure you have proper VSI. We're going to go ahead and take our large syringe and the blue connector. We're going to insert 85 cc's of air into this large
Can
balloon.
you hear that, guys?
Disconnect and test when there's no leaks. And then we'll move on to the smaller syringe with the white adapter. This is 12 cc's of air. Disconnect, test, and redeflate. My next step is to hyperventilate the casualty for 30 seconds. I'm going to place the head in a neutral inline position. Grasping my Combitube, I'm going to insert into the casualty's throat with firm and
I cannot. Hear this very well. You guys can hear it?
the small syringe, taking my large syringe and my blue adapter. I'm going to inflate the balloon,
Hang on.
and the small syringe with the white.
Oh, here we go. Okay.
And then we'll move on to the smaller syringe with the white adapter. This is 12 cc's of air,
You always want to check
Disconnect,
the balloons
test.
first to make sure there's no hole in them.
and redeflate. My next step is to hyperventilate the casualty for 30 seconds. I'm going to place the head in a neutral inline position. Grasping my Combitube, I'm going to insert into the casualty's throat with firm and gentle pressure until the teeth are lined up with the guidelines on the Combitube. Now taking my large syringe and my blue adapter, I'm going to inflate the balloon and the small syringe with the white adapter and insert the small balloon. Now I'm going to take my BBM and first hook it up to the blue adapter up top to check to see if I have rise and fall of the chest. I do with the blue connector. If I did not, I would immediately move over to the white adapter here. Now if the casualty becomes conscious, I want to immediately deflate both balloons. And remove the combi.
Okay, make sense? Okay, all right. So here's a picture of if you had esophageal placement, guys. See right here where my cursor is? So if you have esophageal placement, you're in the esophagus, which is posterior to the trachea, guys. God. So just think, when you do a tracheostomy, you cut into the neck, right? You're hoping your esophagus is not in front of your trachea, because then you cut into your esophagus. So esophagus is behind the trachea. Remember, the tracheal rings are C-shaped. Why are they C-shaped?
To keep it open?
In the back, so when you're
The back,
swallowing,
actually.
the esophagus can expand. Now, okay, you can't, if you have hard cartilage there, that would be a pain in the butt, all right? Okay, so, you go into your esophagus, it's coming down that tube, it can't get out the bottom because it's blocked off at the bottom, so it comes out these holes and the air is directed right down into the trachea. If you were in the trachea right here, if you bagged number 1, nothing is gonna happen. If you bag number 2, you're obviously going to inflate the lungs, okay? All right, King Airways. Come on over here, or here. I want you to compare those airways to what you're looking at right now. And this has replaced the Combitube. Hang on, I'll bring you a King Airway down. Oh, shoot, I don't have King Airway. Can you guys take a look at this again?
Yeah.
Here, move over and compare the two, okay? Tell me, what is the same about them?
They have two inflation.
Two balloons, right? Two balloons. So what do you think the top balloon goes into? Where? The pharynx, the oropharynx. Now, what else, so that's what's the same. What else?